often the decisions fall on one person's shoulders, and that is a very dangerous healthcare environment. It's not easy to reach out for immediate help. It's not easy. You can't get two sets of educated eyes on every patient every time.
Joe Acker is a critical care paramedic and health executive with 35 years experience across frontline practice and senior leadership, including roles as Chief Executive of Ambulance Tasmania, Executive Director of EMS for Alberta Health Services, and now CEO of our foundation. Our second guest is Simon Grosjean, a EMS physician in Astea Valley, Northern Italy, where first-hand experience of pre-hospital isolation drove him to build AI-powered decision support tools for emergency providers in the field. I want to start with this. Dolly McPherson is our Director of Education and went on a ride-along in the ambulance in Ulaanbaatar in Mongolia. And she basically spoke aloud about what was going through her mind as they responded to a drug overdose.
So I guess one of the first things I'd be thinking about is this going to be a dangerous situation? Is there going to be aggression involved? Often you can get acute behavioural disturbances with drug overdoses. And certainly the guys have said that they were holding off to wait for police to get there. So that's obviously what they're thinking as well. And then I'd be thinking about things called toxidromes. So what drug have they taken? How's it going to present? Am I going to have to do something about their breathing or their heart rate to try and resolve it? So I'd be thinking through my clinical approach after that.
But the question is, and this is what's prompted this conversation today on this episode, is what happens in response time is something like 20 minutes, 40 minutes, or on the case of our South African paramedic guests, 3 hours. So I'm going to ask Joe first, if you could just give us an idea of this dead time. What actually is it? And why is it difficult, I guess, for a paramedic operate either solo or with a crew member who's not clinically equal, difficult for that paramedic to start thinking about what they're heading towards?
Thanks, Hamish. It's a great question, and it's something that I think needs to be explored. And certainly there's not a lot in the literature about this. When we talk about dead time, we're not talking about patients. So rest assured, everybody, is not about the patients being dead. It's about the time that is sort of the unproductive, or there's not a cognitive function happening at the time that either a paramedic is responding. That's the time between dispatch and when they arrive on scene. Dead time can also be the time when they're standing in the hallway with a patient, or in the case of long transports, when they've left a facility with a patient, taking them to another patient, they've got this big space of time. And of course, they're engaged in patient care, but often they're alone, sometimes with a partner, but often alone in the back of an ambulance or the back of an aircraft. And there's a lot of time to be thinking. So as you saw in the video, Dolly, who's an extremely experienced critical care professional, she works in helicopters and ground ambulance and clinics and has had a lot of patient contact. She, as a lot of paramedics do, get the dispatch information, which we will talk about later, which is very limited in some cases and actually can have some problems too. But the dispatch information essentially gives you an overview of what you're going to. And that's from the perspective of whoever's calling the ambulance or the helicopter. And that is often not a medical person. So, they're providing the information that they see, answering the questions from the prompts of the dispatcher. So you've got some information of what you're going to. And the first thing we often think as clinicians is, what's the differential diagnosis for this? Is it chest pain? What am I thinking about? Is it an assault? What kind of injuries could this patient have? Is it a seizure? What has caused it? And we contextualize that by the age of the patient, the sex of the patient, the scene that we're responding to. So we start to prompt ourselves to consider what we might expect when we arrive. In the past, before technology now, often it was just, basing we're using past experiences to inform what we might be going to. So for experienced seasoned paramedics, you've got a whole library of case examples and patient exposures to inform what you're thinking about. For novices, you don't necessarily have that big library of cases, and you're often doing it from textbooks or from your instruction or from your simulations. So, of course, more experienced people have more to draw from. We have often had clinical practice guidelines, sometimes in the form of just a card. I remember having a pocket full of different cards when I was starting in my career, where I could flip a card and say, oh, here's my neurological chief complaints, here's my cardiac chief complaints. Virtually every pre-hospital system has clinical practice guidelines or protocols. So you might pop that open on your app and flip to, okay, pediatric seizures. Okay, what do I need to remind myself of? Drug doses, priorities. And if you've got a clinical partner, you can start bouncing questions off your partner. So, certainly when I'm responding to a case, we talk about what our priorities are going to be, what our roles and responsibilities are going to be, and we might start talking down the differential diagnosis. Okay, if we see this, then we're thinking that we'll do this. So I think that dead time period could be super productive. It could actually really make a difference in how we are performing as a team when we arrive. And that is evolving over time. And I'm really excited to be speaking with Simon today, who can talk about how the future, embracing technology and using AI and AI coaches, can actually probably do a much better job than we've been able to do in the past to help focus us on what we're going to see when we arrive and develop our plans of action when we arrive much more scientifically than we have been in the past.
Well then, Simon, what goes through your mind as a doctor responding to some trauma in the Alps that you might be on your own or maybe with a paramedic or another colleague, but certainly if you're on your own, what goes through your mind and how do you clinically prepare yourself for that particular scene that you might be going to?
Yeah, thank you for the question, because actually it was something like that pushed me to kind of produce what I did with MC, with this AI, because I was going. It was a night, I remember. The call was really complicated because it began with abdominal pain with a young woman. On the way, it was like a 50 minutes ride. On the way, we discovered that she was pregnant and she was delivering a baby, but with podalic presentation, so breech presentation, which is really difficult. We usually have some possibility to have a consultancy with a gynecologist by phone, but at the moment, the only hospital that we have in Aosta Valley, the gynecologist was busy, so I couldn't speak with anybody. And I was kind of panicking in a way because, it's really complicated. In the Aosta Valley, we don't do so many deliveries at home. So it was like, okay, let me think about what I'm supposed to do. So I check on the website, I had my mobile, I took out my notes, my paper notes that I had from my formation, my training, let's say. And in the end, everything went well, but not because of me, because physiology worked well, actually. So the girl did brilliantly. The baby was just perfect. So in the end, it was like, okay, this time I was lucky. I think so. Everybody was okay. But in the future, I don't want to feel myself anymore in that position, because I had the Google, I had the mobile, I had all the information in the world, but I couldn't find a way to collect the real information that I needed at the time. So I went looking on YouTube for some videos, I went looking on PubMed for some publication, I went on some blogs, and so I was like searching information desperately without finding the real good one. I find myself in that really difficult situation, and it was in 2024, around November. ChatGPT was coming out, becoming little by little more and more efficient in answering, let's say, medical questions. And so the day after, I said, okay, I have to do something, and because all the 50 minutes that I spent driving to the target, it was spent useless, because in 50 minutes with the new technology, I could make a much better work. In the ambulance, especially in Aosta Valley, we are alone. We are the only physician. We don't have a nurse on the ambulance, and the driver are EMT. really good person, really well trained, but still not physician, not nurse, not paramedics. So we are really, really alone. What we have sometimes is the possibility to have some colleague from the hospital to giving us advice, like a cardiologist, gynecologist, pediatrician, and so on. But in that specific case, it was not possible. So that's what triggered my ideas, like, okay, maybe that technology could help in that space, that time from call to target, like a briefing with a colleague. I explain the dispatch scenario. Can you help me out with posology, for example, with the for the kids, with the pediatric patient especially? Can you help me out with differential diagnosis, or something like a bridge presentation in a young woman? That specific clinical case was what was pushed me to try to find a way to put that technology into my work. So it was like a really personal need, actually.
And I think from the sounds of it, there is not a lot of research, as Joe mentioned, about the dead time and also the impact on mental health for paramedics. As you say, you remember some in that particular case, and it's ingrained in your mind. I wonder then, Joe, a lot of paramedics would have those ingrained experiences. Had they, had it gotten bad for them, it could have been career-ending, I guess.
Well, I think so. And I think that the nature of pre-hospital care, particularly in non-physician systems, is that paramedics don't have a lot of access to information after the case. We get a lot of biases because we transport a patient to hospital. We don't often have a colleague to talk to immediately. In some systems, you can consult with a colleague or a physician, like my system does right now, and you can get some advice. But once we hand over patient care, generally we don't know what happened to that patient, and it's not because we're not interested. It's because in many systems, Australia and Canada, paramedics aren't part of that health system in terms of having access to patient information after we hand over care. There's quality assurance processes you can go through where you can say, hey, I'm really curious to what happened to this patient. It's for my own professional development, and somebody can go and get you some information. Those are really rare. So I think a lot of times you hand over a patient, and as you said, Hamish, it's stressful. It might have been a really complex patient, like the one Simon speaks about, the halo, the high acuity, low occurrence patients that you might not see very many of. You hand over the patient, you don't know what happened to them. You don't know, first of all, you don't even know what the diagnosis really was. You know what you were treating for. You don't know if your treatment made a difference. And you leave that situation maybe stressed out that was a difficult call. But I think worse is that we leave that situation believing that we were treating the right thing and believing in a diagnosis that we actually it hasn't been confirmed. I'll give you an example. Is a lot of there's been some research, and I was part of some research in Australia about treating patients with pulmonary edema, which we don't see very much anymore because it's better medically controlled in the community. But paramedics would get very aggressive in treating pulmonary edema with diuretics and positive pressure ventilation and CPAP, only to find out that the diagnosis was pneumonia. So we go treating a presentation, or we treat 5 presentations of pulmonary edema, thinking it's pulmonary edema, never knowing that the ultimate diagnosis is pneumonia. So for my whole career, I'm treating this patient subset wrong, incorrectly. And I think that is something that we can help correct that with technology. The correction for this is to fix our health information systems where paramedics are part of the team and have access to the patient records in a way that allows us to learn. But I think technology can also help us to broaden our thinking. I spoke earlier about the dispatch to arrival on scene time is super important, and there's a lot we can do in it. I think it's kind of a desert right now. There's not a lot happening. It's very dependent on the clinician on what they're doing with that time. Often, in my observation, they're just doom scrolling their social media, waiting until they get to the patient, and they figure it out when they get there. Where I think we can do better by preparing for those. But the dispatch systems around the world, so medical priority dispatch system, kind of the most common one in North America, Australia uses it as well. There's Paramedic Pathways in the UK. There's Manchester Triage. The systems are designed for us, often a civilian call taker, to take a call from a person in the community, a bystander or a patient, to triage it, asking a number of questions, put it in a classification, send that out to the ambulance responders, fire responders, first responders, whoever. the goal of a triage system is to basically identify the acuity and assign the right resources. And that's kind of where it ends. That's the function of it. And it's a really hard job. Our dispatchers do an incredible job of doing the best they can with the information they got to help us out. But a lot of paramedics and clinicians get that information and they believe that that's what they're going to see when they get there. So if the dispatcher tells me I'm going to chest pain, I'm immediately thinking chest pain, and that patient, when I arrive, will have chest pain until proven otherwise. And there's a big problem with tunnel vision. So because we've got this information, we on the whole way, we plan on what we're going to see. And that's how we start treating, even though it presents as something completely different. So I think that's the other opportunity we have, is to broaden our thinking. So we get a chief complaint, abdominal pain, and we can think of all the potential possibilities that that patient might be presenting with when we arrive, instead of just getting the tunnel vision from the dispatch information.
Well, Joe, as a highly experienced paramedic and now back on the road, can you paint a scenario of a difficult case that you've got very little information about? And then, Simon, can you step in and explain how your AI tool could assist Joe in responding to that call? What sort of information could Joe get from your AI that would help him in that vacuum, that dead time?
So I think one of the most common cases that paramedics get dispatched to, ambulances worldwide get dispatched to, is chest pain. And it also provides us, in many situations, one of the best opportunities to change patient outcome, which is pre-hospital fibrinolysis or direct transport to a cath lab. So those kind of two options for a patient that presents with a ST elevation myocardial infarction. So most ambulance services that in kind of Western world can do 12 lead ECGs in the field, identify whether a STEMI is present, and then treat it appropriately. The treatment is fairly simple, but also has a number of potential outcome or complications. So administering fibrinolysis or a clot buster to dissolve the clots. And we know that the patients have the best outcome when we give it as soon as we can. So if I'm called to a chest pain, my immediately thinking is, okay, how do I determine that this is a STEMI? How do I treat the STEMI safely? Is the patient over 75 years old? Do I have drug doses that I need to alter? If it's not a STEMI and it's a non-STEMI, but it's still cardiac, where can I take the patient? How quickly can I get them there? So a number of things I need to consider. And the whole other part is it's not cardiac at all and it's something different, which takes me down a whole different pathway. So I think that's a really good example of me and my partner preparing, because in my system right now, we have time targets. Like we have to get a 12 lead within a couple of minutes. We have to get a patient history and consent within a couple of minutes. We have to talk to a cardiologist to go ahead with the medications. We have to have an IV started, and we have to give a series of 3 or 4 different medications in a very short period of time to have the best possible patient outcome. So we have to be very organized on scene to do all of that stuff. But there's a number of decisions that lead us up to that point. So very experienced paramedics can do it quickly. Novices will really struggle with that. And I think Simon's solution might be able to help us do this better.
So Simon, Joe's responding, and he's going to go onto your app, and he's responding to that chest pain. So what information can he obtain from your app that's going to help him on scene in such a very stressful period?
Yeah, imagine yourself, you're at home with that person. The person is telling you that she or he is feeling pain in the chest. It's the first time that he had this pain, so it's no history of cardiogenic problem, let's say. But he say, I take a lot of medicine and everything's on the table. Right now I cannot tell you what, because I'm feeling too much pain. I've also been visited by a cardiologist 1 week ago. You find a paper on the other table that I have to do all the stuff that Joe said. So I'll take a line, prepare for the ECG and whatever, think about it. But I still, as we know, anamnesis history is one of the most important things in the clinical presentation of the patient. So with my app, for example, you can take a picture of the drugs, of the boxes. For example, in Italy, we have the boxes of the drugs, or all the names put together. take a picture of the clinical visit of the cardiologist of the week before. And while I am doing all the practical stuff like making an ECG, taking a line and so on, my application is like, okay, the clinical case is the dispatch, what they said, pain, age, whatever. But still, now it has anamnesis from the cardiologist and pharmacology from the picture that they took. And in all this scenario, I can decide, for example, that the person has already anticoagulants, for example, so I have to do other stuff. Or otherwise, the person actually told me that he didn't have any cardiac problem, but on the cardiologist paper, I see that he was complaining shortness of breath 1 week ago, for example. So I can change my mind and try to think what to do after that I have the ECG, for example, because ECG, as Joe said, it can be, for example, STEMI or not STEMI. Now we are evolving to OMI paradigm, so occlusive myocardial infarction or non-occlusive myocardial infarction. So we have all those STEMI equivalents. We have some tools, not directly in my app, but there are a lot of tools that can help us analyze the ECG as well. For example, we have a lot like PM Cardio from Europe, and I think in almost every country is developing his own application for ECG interpreting. And MC can be like the brain that put all the information together, my visit, my clinical instinct as well, the drug information, the cardiologist history. If I have some more information, I can put together, and then while I'm doing my stuff, that brain can like put all the things together and propose me a few scenarios. It's not the solution. It doesn't work instead of me, but it's like a really good person, a good librarian that take all the stuff together, and with the help of literature, because artificial intelligence is not inventing almost anything. Sometimes it's like us hallucinating, but that is a technical stuff that we have to solve. But usually the most modern is not inventing, it's like taking together and trying to find a solution. So while I'm doing my job, after that I can, with the ECG, with the history of the patient, I have like just a summarization, because what I try to do with MC is not like an encyclopedia, like Claude, ChatGPT, Gemini are really explaining maybe too much for EMS word. So it's like just a summary of what I'm about to do, what I should do, and what I should consider like an alternative of that clinical scenario. So this is more or less what MC can do on the clinical scenario, because there on the target, sometimes I don't have time to think about all those stuff. I don't have time to analyze all the drugs and say, okay, are there any incompatibility? We work with the Food and Drug Administration encyclopedia, let's say, and also with the European Medical Agency, so we can see if that drug that the patient is taking has some interaction with what I would like to do. Sometimes I have everything in mind, but other times the medication are so complex that it's not so easy to understand at a site if what I'm about to do is okay, or maybe it's better to withdraw or ask for another opinion from an expert, from a cardiologist, for example.
So Joe, you have that tool in your hand, that information in your hand. How would that impact your decision making?
So, as Simon said, the decision making is ultimately up to the clinician. But what it does for me, it gives me more information. So I'm getting the information, from the patient, from my monitor, from my other lab tests, if I've got a lab, point of care testing, and then it's allowing me to put all that information in and give me some options, which I think is really helpful to give me the other differentials, even if they're the wild and crazy things that I might not normally see. The fact that the app would present that, hey, you should consider this, I might do a little bit more due diligence to rule that in or to rule that out. So I think ultimately it's about patient safety. It's about supporting the provider to do their job even better and even safer and much more efficiently, because I don't have the time to flip through a whole bunch of apps or to flip through a whole bunch of CPGs or to do a bunch of searching online. What I love about what Simon's doing with MC is it's all in one place. It's one prompt, and it's a voice prompt even. So I can just talk into it, record records it and then transcribes it and then enters it in. And then I can scan through it and say, okay, oh yes, here's something or something else I need to question. And yeah, I just did one the other day actually with a patient, and I used the app, and it said, oh, here's 5 questions you can ask to help assist with your history taking, which most of them I was going to ask anyway, but a couple ones I thought, oh, that's fantastic. I wouldn't have done that normally. So I think it's helping you in real time, but it's also making you a better clinician for the long term, because you're actually learning as you go. It's not just a one and done. It's actually helping you layer on your practice. It's experiential too, because you're seeing it in real time and learning in real time, which I think is incredibly valuable.
And I guess the fear is that the AI app would take over and make decisions for you. But it seems pretty clear to me from what, Simon and Joe, you're saying, is that really it's a guide. It's not a decision maker. It gives you those options, but really clinically you're still in charge. But is that a fair assessment?
I saw the potential and also the danger of artificial intelligence. Like, I don't think that we should be put apart and just robot working instead of us, because I think that my work is really nice. I love it. I think that the human touch is more important than knowledge itself. So what the feeling, the smell, the sensation that I have with a quick look, that it would be impossible to copy with a machine. But still, it's a really nice tool. It's a really powerful tool. So why I decided to use it and to try to develop, it was like, okay, we have this really powerful stuff. We have to push ourselves in order to make something really useful for the patient first and for us as well. During the dead time, during my shift, I like relaxing. Before I was like going on Instagram, Facebook, or whatever. Now maybe I can do something that MC is proposing me, like, okay, you just went on a really difficult scene on a pediatric. Maybe you should train more on pediatrics. So just train together. And so that's why we also put what we call MC Arena, because it's like a fighting arena where you can go there, fight and test yourself against people, against in a good way, of course, and against yourself especially. So it's like training yourself, trying to push harder. So the next time you will know more things, because it's like cleaning your knowledge, putting away useless stuff, and just keeping the most important thing in your mind. It's called a cognitive unloading.
Joe, you're very familiar with Mongolia and that setting. And of course, our project and this podcast is all about EMS evolving in those low resource settings. Joe, where would you see the benefits of the app for places like Mongolia or Africa, or even some post-Soviet nations who aren't well-resourced?
So I think that the application, Simon's developed it with MC, is not just good for the locations you mentioned. It's universally good for a number of reasons. First of all, it's on your phone. Everybody has a phone. We work in Mongolia, which has surprisingly good phone coverage.
Yes,
in fact, my phone coverage when I'm in Mongolia is better than it is where I am in a city in Canada sometimes. So everybody has a phone. Phone coverage is good, but it's like frictionless. It's one app. It's all there, and it's designed to pull the solutions recommendations from the appropriate literature. So Simon said it's not pulling it from every possible piece of information on the internet and presenting you this huge amount of information. It's presenting you the information that's appropriate for out-of-hospital emergency care, using the best resources, whether it's PubMed or resuscitation guidelines, that's contemporary and accurate. In the past, when I had my phone, if I'm doing a pediatric case, I'd have a pediatric app. I'd have my ambulance service clinical practice guidelines. I'd have another app for like med calculators. I might have another operational app. So I'd have all of these things. With MC, you can do it all in one. So you just put your query into it and it pops it up. So I love that for the people that we're working with, the ambulance drivers and ambulance doctors in Mongolia. They would have this really frictionless, user accessible, easy way to get answers to their questions really quickly in real time. I also love the training part of it, that on the downtime when you're if you ever get a break in ambulance, which most of us aren't anymore, in between calls or after a call or while you're waiting in a hospital or service time, you can just test yourself with 5 questions on something you identified a gap: obstetrics, neurology, pediatrics, cardiac. You'd say, I've got a little bit of time. I want to challenge my brain a bit, and you can just zone in and do that. And I like that it's all in one spot. So I think the developed, the low and middle income countries, this is, relatively low cost, seamless, easy way to put it all in the palm of their hand. And it's not about reinventing the wheel either. It's something that as a group like us, EMS Global, we can share across all the agencies that we're working with.
But you've got a paramedic who's well experienced, who says, I don't need AI, I can treat the patients just with my expertise and within the protocols. I don't need this, all this stuff with me. What would you say to that paramedic? The people who resist change or resist technology?
Wow. So my experience from being in a leadership role
Yes.
is that some people will never change. So don't waste a lot of time on them. If they're absolutely entrenched, they'll retire sooner or later and just move on from them. But I think it's about encouraging people who might be less likely to pull up an app and try it out, to show them the benefits of it. That, this is actually about you as a professional focusing on what you want to do. Like, you're asking the questions that you're curious about. And I think because if I'm feeling vulnerable because my 12 lead ECG interpretation skills aren't very good, I might not feel comfortable to raise my hand and talk to a colleague or an educator or my boss because I feel I should know that. But I can privately chat with my AI assistant and get some really good focused training. And I think that's what's really helpful about this is it's an authentic engagement. It actually feels like you're actually working with somebody else, but it's the AI tool. You can ask the questions that you feel too stupid to ask somebody else, and you can improve your practice. And I think especially if it's fun or if it's gamified, like the arena, or if I can have a couple of colleagues and I can challenge them to a cardiology, beat down, and I can see if I'm smarter than they are in cardiology. These are kind of fun things that I think the clinicians that work on ambulances would really enjoy.
What will it take, Simon, for this to work at scale with the app? You're going to be running a pilot program with EMS Global in Mongolia this year, to see it in a very, very resource constrained environment. What are you looking for to make this happen in reality for EMS worldwide? As Joe said, it applies everywhere. What are your thoughts and plans from here?
Oh, this is a really difficult question, actually. And I think that's what we are starting to do here in Nafsa Valley and with my colleagues, with my friends. Sometimes we have some doubt, like, okay, I'm not sure about that. And we say, why? Ask MC. Like, is the new language, like, why not? Let's ask MC, and so let's see what he says. We don't know if it's perfectly right, because sometimes there is no right or wrong in medicine, especially. But just try it, just play with it. Don't be shy. So what I would like to do, and I'm really thrilled to start this collaboration with you guys, is that if in a place so far from me, culturally different, because it's not something, they don't speak my language, they don't, I think, even write with my alphabet, and they have another language in mind, they work in another place, they are a different profession from me, and if in that place, so far from me, they can use MC and they can enjoy using it, and especially the patient that they are caring to is improving, I think that is the best thing that I can get, because for me, MC is not something about money, like scaling, like a startup and so on. MC for me is and will always be a project to make this technology available for as much as possible people. So from all over the world, in my idea, that's why we want to keep it at least apart for free.
I want to not turn this into a sales pitch. There is going to be downsides. And what I like to do, just sort of as we start to wrap up, is this question to Joe. Simon's come to you and you're the head of Ambulance Tasmania. What doubts would you have about the app? What would you question before you implemented the app across Ambulance Tasmania? And what would you be asking from Simon to make you feel more comfortable?
Well, as a true bureaucrat, you always have to ask about the costs. What's this incremental cost, and ultimately, what costs can I avoid by implementing it, or how can I make my system better by implementing it? Can I make it safer? Can I make it better for the staff that work within it? Our pre-hospital providers are busy already. Our doctors and nurses and drivers and paramedics they have so much cognitive load from everything that they're doing. They're driving a vehicle or they're in a helicopter. They've got safety issues. They've got tons of different technology, electronic patient care records, radio systems, satellite phones. They've got operational things they need to do. They got to figure out their destination. They've got to think about the next call they're going to do. Like, there's so many things that we're asking our out-of-hospital providers to do that layering one more thing on, it might be the straw that broke the camel's back. Like, we're now saying, okay, now you need to talk to the AI on the way to a call or reflect on it after. I think we have to say, hey, let's find ways to take out a bunch of this cognitive load you have in your job by replacing it with something like MC. And I think systems are trying to find ways that we can communicate better with each other and with our patients. Translators are out there too. That's another thing that we put on top of it. Voice recognition to do our documentation. Like, if I can speak into MC and now it can actually do my electronic patient care record framework, and I just have to add a few things and make sure that it's right and save myself a whole lot of documentation time. That's a value add. Maybe the system checks in with me on my mental health. How am I at the beginning of my shift? How am I at the end of my shift? Can you give me some ideas for, I don't know, how to be happier in my job? Like, I think that the sky's the limit. Like, this is the tip of the iceberg on what could be actually something that makes the life of the provider better, and the benefit too to our patients could be significant. We know that, like, pre-hospital care is kind of in the shadows of healthcare. Nobody's out watching it. Nobody's looking over our shoulders. We're independent practitioners. We're often working with somebody who's at a different level than us, whether it's like in Mongolia, doctors and drivers, or here with a paramedic who's a primary care paramedic or advanced care paramedic, or a doctor and an EMT. Often the decisions fall on one person's shoulders, and that is a very dangerous healthcare environment. There's not easy to reach out for immediate help. It's not easy. You can't get two sets of educated eyes on every patient every time. So the more we can use technology to help us for a better paramedic experience or pre-hospital care provider experience and a better patient experience, I'm all for it. I think that executives and decision makers would be looking to something like this to say, hey, can I make this environment better and safer?
So to wrap up then, I'll go to you, Simon. And what are your thoughts about what Joe's just relayed as a leader in EMS? Is it something? Has he nailed what you're trying to achieve and what the app actually offers?
Yeah, actually, thank you, Joe, because you explained everything so perfectly. Something that it's even in our thought, actually, not yet something that we are trying to deploy. But I think that you said it brilliantly. We have too many things. We have the monitor, we have the tablet with the things that we have to write on. We have the dispatch center calling us via radio, mobile, whatever. I'm in the ambulance. I don't have time to write down things, but I can speak. I'm doing adrenaline right now, like in a cardiac arrest scenario. The team is speaking a lot. We are getting good to speak a lot together in order to be a good team. And if someone is listening to us, it can scribe down what we are doing. So like adrenaline done at that time. After 4 minutes, some voice will say, did you do adrenaline? And it won't be the team person, but it will be the tablet speaking and telling us, did you remember to do the rhythm check at that time? Okay, I see the rhythm with you. For you, it's asystole or is like a fine ventricular fibrillation? Okay, let's consider a little bit. Let's keep on going. So I think that MC will be really useful in that scenario where the technology is not something new that you have to buy because it's something cool, you like it, so you buy it, but it will be something that will be the root of your system. The idea, at least, is already there, is that MC has to be like the bridge that can put everything together. So like making bridges, that is our idea.
And as an executive, I would love that. What Simon just said there about bringing it all together. Like we do in the back of an ambulance, we have a video laryngoscope, we have an ultrasound, we have a monitor, we have a tablet, we have radios, we have all of this technology. And although there's a lot of organizations trying to bring that all together, it doesn't happen. Like we have to log into so many different things using so many passwords. If we can take a lot of that friction away and put it all in one place and have it and reduce the duplication and also have a smarter system that helps us as clinicians, I think that's amazing. That's the future.
Simon and Joe, thank you for a very engaging glimpse into the future. And Simon, we're looking forward to working with you as part of EMS Global Foundation in Mongolia and looking at the application of the technology, and I'm sure that Joe will give you his feedback once that's completed. So Simon and Joe, thank you for your time on this podcast, and we'll look forward to talking with you again in the future.
Thanks, Amish.
Thank you.